acute management of pelvic fractures per se, or as a part of polytrauma, or as open pelvic fractures, or some part of it is often asked in the exam. Now in trauma paper, if they want to ask you on pelvic injuries, this is the topic that they usually ask rather than the classification, because it's very vital as a resident and as a consultant to know how to treat these injuries, right? Not a definitive part, but the acute part when the patient presents to you, because that's what decides whether the patient is going to live or not. So we have been through this in the last week or last session rather, how to classify it: lateral compression, anteroposterior compression, and vertical shear. But no matter what pelvic injury the patient has, the acute immediate management remains more or less the same. So it doesn't actually matter what fracture the patient has. We'll deal with some of the myths that have come over a period of years. But why I'm highlighting this point is that pelvis AP radiograph is not an emergency to get when the patient comes with a polytrauma. Okay. Just the identification of the fact that the patient has pelvic injury is good enough. We do not need to know what exactly is the mechanism of injury and what is the subtype. We don't need to know that, because once the patient is stabilized, we can always get for the radiology and the CT if required, but we do not need to rush to get a pelvis X-ray to begin with. Okay, so any pelvic injury, we know that it's a part of high velocity injury. It's not that the patient you come across a situation where the patient has just had a trip and fall and he had a pelvic injury. That is extremely rare. Only in elderly osteoporotic you may find that, but in most cases, especially in young, we find that it is due to high velocity injuries. So keeping the pelvic injury aside, we need to see the patient as a whole. So the typical ATLS protocol we need to follow, start off with A, B, C, D, E, no matter how the patient is. Okay, so why this is to be done is you keep practicing this in each patient, no matter whether the patient is polytrauma or not, but you keep practicing this protocol in each of the patients, you will become such an expert that when the day really arrives that you have a polytrauma in your hands, you will not miss what has to be done. Okay, so it doesn't matter that you do this exaggeratedly on 99 patients who do not actually fit into the definition of polytrauma, but that the one patient who really comes with polytrauma and you do not follow definitive protocol, most likely you are going to lose the patient. Okay, so that one saved life is good enough for you to waste time on the other 99 patients who actually did not have. Okay, so do not forget this, follow the same protocol, and considering all others are taken care of, the patient is borderline or stable or unstable, and you know clinically that the patient has a pelvic injury, so what needs to be done? So we need to understand that all these polytrauma patients, there is this triad of death. What are the components of the triad of death? We have metabolic acidosis, hypothermia, and coagulopathy. Now, remember that just by the fact that the patient is in shock, he has lost a lot of blood, there is already metabolic acidosis even before the patient presents to you. Okay, that happens. Coagulopathy happens because of significant bleeding internally, leading on to dilution of coagulation factors. So these two entities the patient already has, and more often than not, we receive the patient in trauma bay or in emergency where ACs are on, or we disrobe the patient, we expose the patient just to see if there are any injuries, and that subtle period of time is good enough for the patient to go into hypothermia, and then we are giving the patient the third entity. Hypothermia doesn't exist by itself, it is usually iatrogenic. Okay, so that is what we need to take care of, that even when we are disrobing the patient for exposure, we need to see to it that the patient is well, doesn't go into hypothermia. So we should not push the patient into the triad of death. So why, what exactly happens? Why are pelvic injuries unlike any other injuries in the body? Now, there are much more severe injuries like head injury, thoracic injury, abdominal injuries, but pelvic injury is little different. Why? That is because there is no tamponade effect on the ongoing bleed. Now, no matter any other cavity, if we consider intra-abdominal cavity or intrathoracic cavity or even intracranial cavity, once the bleeding starts, because of the increased pressure within the compartment, within the content, the tamponade effect prevents or rather stops further bleeding. But that doesn't happen in pelvis, because we know that the volume of a cylinder is 4/3 pi r cube. So volume is directly proportional to third power of the radius, right? So it is exponential. So when the radius expands, so when there is a pelvic injury, there is no restraint for how much the pelvic can expand. We have seen that in APC injuries, both the anterior and the posterior, all ligaments are gone. So there is no any stabilizer of the pelvis. So it can just keep on expanding to such a huge volume. And with each, say, millimeter of expansion in the radius, we know that the volume is expanding 3 times. So there is absolutely no tamponade effect. He can keep bleeding until there is total loss of all the blood within the intravascular compartment leaking into the extravascular component, and the patient can die just because of that. Okay, so that is why a pelvic injury is unlike any other injuries, because there is no inborn tamponade effect. So that is where we as surgeons need to understand and play a role in trying to reduce the R component, that is trying to reduce the radius component, trying to reduce the expansibility of the pelvis. So what can we do? So something to overcome an indefinite expansion of the pelvis. So we can just put some pelvic sheet or binder. Okay, mast, we'll come to each of this. Okay, mast, external fixator, quickly in. All these we'll see to it that the pelvis doesn't expand beyond a certain limit. Okay, so we are giving that restraint to the pelvis so that the tamponade effect can develop within and the patient can stop whatever ongoing bleeding that he is currently having. Okay, if this does not stop bleeding, further bleeding, then the patient has to be taken for something more. Usually it is the angiography, and even then, if it is not controllable or if it is not an arterial bleed, we should move on to pelvic packing. Now these are the levels of care in a pelvic injury, so we should be ready for it. The moment the patient comes, it is stepwise manner. You do the step 1, that is pelvic binder. If it does not respond, the patient is not stabilized by that, move to an X-fix. Even with that, the patient not stabilized. Depending on the availability, we can do an angiography. If not, we can set off to an laparotomy and do a pelvic packing. Okay, so it should not be that we wait for things to happen. No, that does not happen. If the pelvic is expanding, it is expanding, and has to be our duty to do something to stop the bleeding or prevent expansion. So pelvic binder or a sheet. Nowadays, we are fortunate enough that there are enough commercially available binders in most places, most of the institutes, most of the hospitals that we see. Even if it is not there, a simple plain bed sheet or a thick towel, a large enough towel should be good enough. We do not need to wait for the binder to come, because binder is nothing. It's not that only the commercially available good looking ones are a binder. Okay, so these simple bedsheet or a towel that we can readily find anywhere in the hospital should be good enough to be used like a binder. Only thing is we need to know how to use it. Okay, it need not be of a certain quality or certain subtype. Okay, so bedsheet is what